Membrane defects. Hereditary spherocytosis occurs because of a structural defect in the cytoskeleton of the red blood cell, usually an abnormality of the protein spectrin. The red cells released into the peripheral blood appear morphologically normal, but as they circulate they lose their membranes, principally in the spleen. As more of the cell membrane is lost, the shape of the red cells changes from a biconcave disc to spherical. Red cell survival is reduced, with the spherocytes eventually being destroyed in the spleen. There is wide variation in the clinical manifestations of this condition. NB. The spleen destroys damaged spherocytic cells. Significant clinical illness can be treated by splenectomy, which enables spherocytes to live longer in the absence of the spleen. In an adult, anemia may lead to tiredness, lethargy, and reduced exercise capacity. This may also be true in children, but height, weight, and school performance can be more useful markers of the effects of disease. Most cases of hereditary spherocytosis are inherited in an autosomal dominant fashion, with the severity often breeding true. Asking about the severity of the condition in older affected members within the family may give a guide to the extent of problems the individual is likely to experience. Particular attention to the following is warranted. 1. Chronic hemolysis often leads to the formation of pigment gallstones, so document the frequency and severity of episodes of biliary colic and cholecystitis. 2. Infection with a parvovirus may precipitate an aplastic crisis, the frequency and severity of which should also be recorded. The degree of hemolysis in patients with hereditary spherocytosis is very variable, and this is reflected by the level of hemoglobin, Hb, which may range from normal to severely anemic, Fig 17. The reticulocyte count is usually raised at between 5 and 20%. Because the spherocytes have a reduced cell volume and the reticulocytes an increased cell volume, the mean corpuscular value usually balances out within the normal range. The mean corpuscular Hb is often normal, but the mean corpuscular Hb concentration will be raised because of the relative reduction in cell volume compared with cellular Hb. Aplastic crises may occur following viral infection, in particular by a parvovirus, which may lead to severe anemia with no reticulocyte response. The direct antiglobulin test will be negative, whereas it will be positive in autoimmune hemolytic anemia. Hyperbilirubinemia is common. In hemolysis, the majority of bilirubin will be unconjugated and the liver enzymes should be within the normal range. In contrast, in common bile duct obstruction, bilirubin will be conjugated and liver enzymes will often be raised. Spherocytes have reduced resistance to osmotic lysis, Fig 18. An increasing degree of hemolysis of normal cells occurs in progressively hypotonic conditions, but spherocytes are more susceptible to lysis at any given concentration of saline. Reticulocytes are more resistant to lysis than normal red cells, and the reticulocytosis in hereditary spherocytosis is reflected in the tail of the curves. A positive test is not diagnostic of hereditary spherocytosis, but simply indicates the presence of spherocytes for any number of reasons. Chronic hemolysis often leads to folate deficiency, and treatment of this may lead to symptomatic improvement. Many hematologists recommend folic acid 5 mg daily prophylactically. Splenectomy will significantly reduce hemolysis, correct the anemia and resolve the clinical problems, but these benefits will need to be weighed against the surgical risk of the procedure and the lifelong increased risk of infection in patients after splenectomy. If splenectomy is proposed, then the following should be considered. At least 2 weeks before the spleen is removed, the patient should be given pneumococcal, meningococcal, AC, and Haemophilus influenza B vaccinations, with a booster every 5-10 years. After splenectomy, the patient should receive penicillin 250 mg orally twice a day for life, as prophylaxis against infection, and a yearly influenza vaccination. The patient should be educated and warned about the risk of infection and advised to seek medical help immediately should they become unwell. Individuals should also carry a supply of broad-spectrum antibiotics, e.g. co-amoxiclav, for immediate use should they develop symptoms or signs of infection. Splenectomy for those under the age of 5 years should be avoided if at all possible, as the risks of overwhelming infection are greatest in this group.